The most fundamental concept in health policy is the iron triangle, coined by William Kissick. The triangle has three vertices: access, quality, and cost. The theory posits that these three are in a dynamic tension. You can rarely improve one without negatively affecting the others. If you want to increase access, cover more people, and maintain high quality, the cost will explode. If you want to cut cost, you usually have to limit access, rationing, or lower quality. Politics is essentially the argument over which two vertices we want to prioritize. In the US, we have historically prioritized quality and access for the wealthy, while allowing costs to spiral out of control. To understand why the US response to public health crises is so disjointed, you have to read the Constitution. The 10th Amendment states that any power not explicitly given to the federal government is reserved for the states. The Constitution says nothing about health. Therefore, the legal authority to regulate public health, the police power, belongs to the states, not the president. This is why we have 50 different departments of health, 50 different Medicaid programs, and during COVID, 50 different mask policies. The CDC cannot issue a nationwide mandate. It can only issue guidance. This fragmentation is a feature, not a bug, of our constitutional design. So, how does the federal government get anything done? Money, the power of the purse. The federal government cannot order a state to do something, but it can bribe them. This is called conditional spending. In South Dakota versus Dole, the Supreme Court ruled that Congress can withhold federal funds to coerce states into compliance. They did this with the drinking age, tying it to highway funds. They do it with Medicaid. If a state wants federal healthcare dollars, they have to follow federal rules. This is the primary lever of national health policy. Huge bags of money with strings attached. The result of this history is a fragmented coverage map. If you are over 65, you are in a national social insurance program, Medicare. If you are poor, you are in a state-run welfare program, Medicaid. If you're a veteran, you're in a fully socialized system where the government owns the hospitals, the VA. If you're employed, you're in a private market system subsidized by tax breaks. And if you don't fit any of these boxes, you're on your own. This fragmentation creates massive administrative waste and inequality. A policy that fixes one sector, like Medicare, might completely break another. You need to know the alphabet soup of agencies. HS is the mothership. Under it, you have the CDC, which does science and surveillance, but has no regulatory power. You have the FDA, which regulates drugs and food. They have T's. You have the NIH, which funds research. But the 800-pound gorilla is CMS, the Centers for Medicare and Medicaid Services. CMS controls the money. Because they pay the bills for millions of seniors, they effectively set the prices and standards for the entire healthcare industry. If CMS says, we aren't paying for this unsafe procedure, that procedure disappears overnight. At the state level, the power is more direct. States license doctors and nurses. If you want to practice medicine, you ask the state, not the feds. States regulate insurance companies. And crucially, states run Medicaid. This means that being poor in Mississippi is very different from being poor in Massachusetts. The eligibility rules, the benefits, and the quality of care vary wildly across state lines. This creates a geography of inequity that is unique to the American system. We cannot ignore the private sector. American healthcare is a business. The providers, hospitals and doctors, the payers, insurance companies, and the producers, pharma, are massive economic engines. They spend billions on lobbying to protect their interests. the American Hospital Association, the AMA, and become to write many of the laws that Congress passes. Understanding policy requires understanding the profit motives of these stakeholders. They are not villains. They are rational economic actors responding to the incentives the government created. Because the system is so complex and the stakeholders are so powerful, radical reform is nearly impossible. We are trapped in incrementalism. We tweak the edges. We pass a law to cover kids, then a law to cover seniors, then a law to fix pre-existing conditions. We rarely tear it down and start over because there are too many veto points in the system, too many places for a bill to die. This path dependence means we are often layering new fixes on top of old broken systems, creating a geological sediment of policy. To conclude, Lesson 3. The U.S. health policy ecosystem is designed for gridlock, not efficiency. It prioritizes local control, federalism, and private enterprise over national uniformity. As an ethicist, you might identify a moral imperative like universal coverage, but as a policy analyst, you have to figure out how to get that moral imperative through a Senate committee, past the insurance lobby, and implemented by 50 different governors. In the next lesson, we will look at the specific process of how an idea survives this gauntlet, the policy cycle.